Okay. Or compression bulging this. Normal compression will narrow the span. Trochanteric bursitis, greater trochanteric pain syndrome, GTPS. It causes buttock pain. I think that is it is it lateral meralgia paresthetica, upper lateral thigh. So lateral cutaneous nerve of the thigh is involved. So is it peripheral nerve? Okay. I was confused about what type of nerve. I got the diagnosis, but I don't know the answer. Like, okay, yes, okay, no problem. Meralgia parasitica, etiology lateral femoral cutaneous nerve entrapment or injury due to compression, tight clothing, obesity, pregnancy, and iatrogenic injury. Total hip arthroplasty. Clinical feature is paresthesia and decreased sensation at lateral thigh. Paresthesia and decreased sensation at lateral thigh, normal motor and reflex examination. Management is avoidance of tight garments, weight loss, non-opioid analgesic, NSAID, anticonvulsant gabapentin, nerve block, or surgical release for refractory cases. This patient has localized pain. This patient has localized pain and paresthesia in the lateral thigh consisting of meralgia parasitica. Meralgia parasitica is caused by compression of the lateral femoral cutaneous nerve where it passes under the ligament into the thigh. Patient experience symptoms in the distribution of the nerve but have no weakness because the nerve contains no motor fibers. Extension of the hip where extension of the hip when it's standing or duration examination often worsens the symptoms, possibly putting pressure on the nerve. Myalgia parasitica is often caused by by tight clothing, external compression of tight clothing or belt. The risk is elevated who are pregnant because, especially in the third trimester, due to gravid abdomen and exaggerated lumbar lordosis. The diagnosis of the myalgia parasitica is usually made clinically. No imaging is needed because myalgia parasitica is a benign and self-limited condition. Conservative management, avoiding tight garments, weight loss is usually adequate. Myalgia parasitica is associated with pregnancy, typically resolves postpartum. And the option B, greater trochanteric pain syndrome, GTPS, or trochanteric bursitis can cause lateral thigh pain because the sharp pain is typically sharp and confined to the trochanteric region. It is worsened with ambulation or lying on the affected side, and sensation is not affected. Sensation is not affected. Ab okay. Superficial dehiscence. Abdominal surgery can result in variety of postoperative wound complication, infection, dehiscence. The complications are most common in obese patients as seen in this case, those who are immunocompromised, chronic corticosteroid cancer, and those with increased intra-abdominal straining, excessive lifting or cough. Postoperative abdominal wounds can be categorized. Postoperative abdominal wounds can be categorized based on fascial involvement, superficial wound dehiscence, and deep wound dehiscence. Superficial wound dehiscence is a separation of the skin and the subcutaneous tissue with an intact rectus fascia, as seen in this patient. It is typically within first postoperative week, occurs secondary to an abdominal subcutaneous fluid buildup seroma, resulting in scant serosanguinous fluid drainage, and deep wound dehiscence involves the rectal fascia. Deep wound dehiscence involves the rectal fascia non-intact and results in exposure of the intra-abdominal organs to the external environment. Patients with superficial dehiscence and no signs of infection. Patients with superficial dehiscence and no signs of infection in duration, erythema, pool, and discharge are conservatively managed with regular dressing changes. These regular changes help with delayed closure by removing excessive fluid and closing physiological dead space, which debrides non-viable tissue and eliminates potential bacterial reservoirs. In contrast, is a surgical fascial dehiscence is a surgical emergency because of risk of bowel evisceration and strangulation. Okay. So emergency surgical exploration for deep fascial or deep wound dehiscence. Okay. Oh, rectus sheath. Okay. This newborn with crepitus over the shoulder, asymptomatic moro reflex, and pain with passive motion of the upper extremity. Pain with passive motion of the upper extremity has a displaced clavicular fracture. Neonatal clavicular fracture are typically due to difficult delivery. Risk factors include birth weight for more than 4 kg, shoulder dystocia, vacuum delivery, vacuum extraction can also cause subperiosteal bleed. Cephal hematoma is seen in this patient. X-ray are performed to confirm the fracture. X-ray are performed to confirm the fracture because neonatal clavicular fracture usually heal rapidly within 7 to 10 days with no long-term sequelae. And management include parenteral reassurance and guidance of gentle handling to decrease uh, uh, parental reassurance and guidance on gentle handling to decrease pain and arm motion may be restricted. To decrease pain, arm motion may be restricted by pinning the infant's sleeve to the shaft. Okay. Beta ECG is beta ECG is falling. I think that it's missed. Okay, this patient has missed abortion. An intrauterine pregnancy demise at less than 20 weeks of gestation prior to expulsion of product of conception. Patient may be asymptomatic or have decreased pregnancy symptoms, nausea, breast tenderness. Physical examination reveals closed cervix. Risk factor for spontaneous abortion include advanced maternal age due to associated increased risk for fetal chromosomal abnormality. Ultrasound finding in a missed abortion include either an embryo without cardiac activity. Missed abortion include either an embryo without cardiac activity or persistently empty gestational sac without a pole, no embryo. Although some early pregnancies less than 6 weeks of gestation presents without a fetal pool. Although some early pregnancy less than 6 weeks can come without a fetal pool, gestational sac with or without yolk sac, viability is determined through ultrasound and serial beta ECG. Viable pregnancies have rising viable pregnancies has rising serum beta ECG throughout the first trimester, and imaging reveals a continued embryonic development, fetal pole with cardiac activity. In contrast, non-viable pregnancy has decreasing beta ECG level, and repeat imaging shows halted development. This patient has decreased beta ECG level, resolved pregnancy symptoms, and repeat ultrasound with no further embryonic development, finding consistent with fetal demise. Okay, if we look at the picture, in missed abortion there is no vaginal bleeding, there is closed cervical os, no vaginal bleeding, closed cervical os, and no fetal or cardiac activity. No fetal cardiac activity or empty sac. In threatened, vaginal bleeding, closed os, and fetal cardiac activity is present. In inevitable, just vaginal bleeding, dilated cervical os, and product of conception may be seen or felt or above the cervical os. And incomplete is vaginal bleeding again, and dilated cervical os and some product of conception are expelled. And the complete is vaginal bleeding, closed os, and product of conception is completely expelled. Okay, you want to add something? Okay, yes. Missed means the os is not open, but the fetus is actually dead in the uterus. So, but no product is coming through the there is no bleeding, no closed os, and no activity. It is threatening to come, but it hasn't opened yet. But inevitable is it will open. The os is already open, and product of conception may come out at any time. Incomplete is partially come down of the product, and complete is complete coming down of the product and the closure of the os. It's a rubbery thing, isn't it? Like it has some sort of elasticity on the vaginal wall. So if the product of conception comes out through the vagina, then it will close automatically, isn't it? Maybe. Yes, 120 is normal. And like, I think that baby is sleeping. So awake, make him awake to find out the problem. Okay, this patient has SLE. Because uteroplacental insufficiency may have there may be deceleration, isn't it? Yes. Okay. Okay. I am reading the explanation. Okay, non-stress test. Non-stress test is baseline heart rate is 110 to 160. There is moderate variability 6 to 25 and more than 2 acceleration in 20 minutes, each peaking uh, 15 or more than 15 minutes above baseline and lasting more than 15 seconds. And it is reactive, and non-reactive does not meet the criteria of the reactivity. So okay, so non-stress test is commonly performed for pregnancy. Non-stress test commonly performed for pregnancy at risk for fetal hypoxemia, acidemia, and or demise due to a maternal or fetal comorbidity, SLE, fetal growth restriction, or for decreased fetal movement. During a non-stress test, the heart rate of a well-oxygenated fetus rises with fetal movement acceleration. A reactive non-stress test, normal baseline, moderate variability, and more than 2 acceleration, has a high negative predictive value for fetal acidemia. These patients a non-stress test. This patient non-reactive non-stress test is non-reactive because it has no acceleration. Non-reactive non-stress tests are concerning for non-reactive non-stress tests are concerning for fetal hypoxemia and acidemia. However, the most common cause of non-reactive non-stress test is a quiet fetal sleep cycle which lasts less than uh, 40 minutes. A typical non-stress test is 20 minutes, but non-reactive non-stress test is extended 40 to 120 minutes to ensure that fetal activity outside of quiet sleep is captured. Due to a high false positive rate, non-reactive non-stress tests are further evaluated with either a biophysical profile or contraction stress test before concluding the fetus may be hypoxemic and need intervention. Got it? Yes. Congenital fetal heart block is a complication of the SLE or Sjogren's in pregnancy due to anti-Ro and or SSA antibody crossing anti-Ro or SSA antibody crossing the placenta. However, fetal heart block typically cause fetal bradycardia less than 110 minutes, not seen in this patient. Fetal head compression causes early deceleration. Fetal head compression causes early deceleration. This is the early deceleration. Look at the picture. You understand this, isn't it? Okay. It is not that hard. Okay. There are some sort of deceleration. Deceleration means the what can I say? Deceleration means downwards and acceleration means outward. Deceleration is always bad. Look at the graph of first upper portion of the graph. First fetal heart rate and below is uterine contraction. Yes. Okay. From onset to nadir. One small square is 10 seconds. So if it is more than 30 seconds, look in here from onset to nadir, it take near about 1, 2, 3, 4, 50 seconds. So more than 30 seconds. So from onset to nadir, it is more than 30 seconds, and it coincides with the uterine contraction. So it is early deceleration. Yes. Okay. So this is, and deceleration is always bad. Every time there should be acceleration. Acceleration is good, deceleration is bad. Okay. Now the fetal head compression. causes early deceleration shows decrease in fetal heart rate that occur with contraction. They begin deceleration. These benign deceleration are likely the result of fetal autonomic response to the alteration of the intracranial pressure caused by the contraction. There are no deceleration or contraction on these non-stress tests. So within this uh, test, we haven't found any sort of deceleration, just up and down, not that down like this patient, like this early deceleration. Okay, got it? Okay. Now look at the uteroplacental insufficiency first. It causes late deceleration. Have you found the late deceleration? Again, the same theory goes like in case of fetal heart rate, it is more than 30 seconds. But from onset to nadir, first uterine contraction, then the fetal heart rate. So it does not coincide with the fetal heart rate. So that's why it is late deceleration. So for early and late, for the deceleration, the graph has to go downward. The fetal rate has to go downward. And if it coincides with the uterine contraction, it is early. And if it does not coincide with the fetal heart rate, it is late deceleration. Okay. And for early deceleration has mainly two causes like fetal head compression and can be normal fetal tracing. Sometimes early deceleration can have normal fetal tracing, but the late deceleration, the number one cause is uteroplacental insufficiency. Got it? And there is another form of deceleration called variable deceleration. And how will you distinguish the variable deceleration? Variable deceleration is onset to nadir is less than 30 seconds. That's it. There is no coinciding part in that deceleration. Less than 30 seconds. And the cause is like and the okay cause is like COC. Look at here. Can you see my screen now? Now you should. I have now. Yes. This is the variable deceleration. Okay. Uh, Look at through magnifier. Okay. Okay. It is less than 30 seconds from onset to nadir. Got it? And there is nothing need like it should not coincide, or we do not need that criteria in here. We need that onset to nadir is less than 30 seconds. Got it? And the example for here is like the cord compression, oligohydramnios, and cord prolapse. Okay. Okay. This box is very important. Yes. Six. In 26 to 28 weeks, we do the uh, GTT. Yes. Okay. First the box. Okay. um, for initial prenatal visit, we do Rh type antibody screen, hemoglobin hematocrit, MCV, ferritin, HIV, VDRL, RBR, RPR, HBsAg, anti-HCV antibody, rubella, varicella immunity, urine culture, urine dipstick for protein, chlamydia, PCR, if risk factor are present, and pap test. In 24 to 28 weeks, hemoglobin hematocrit, antibody screen if Rh negative, 1 hour 50 gram GCT. And in 36 to 38 weeks, group B streptococcus. In 36 to 38 weeks, group B streptococcus rectovaginal culture. During the second and third trimester, of the pregnancy, placental hormones increase maternal insulin resistance and blood glucose level to promote fetal growth. Patients with inadequate pancreatic function to overcome the increased insulin resistance to develop gestational diabetes mellitus. Risk factors include obesity, excessive weight gain during pregnancy, or family history of diabetes mellitus, or a prior macrosomic infant. Because uncontrolled maternal hyperglycemia increases the risk of obstetric complication, miscarriage, congenital defect, fetal macrosomia, preeclampsia. All patients at risk for type 2 diabetes mellitus, obesity, affected first degree relative require diabetic screening at the initial prenatal visit. Hemoglobin A1C and GCT. Patients with no identifiable risk factors, such as this patient with normal BMI, require a routine OGTT 24 to 28 weeks, which is typically present. Placental hormone induce insulin resistance. The most common testing approach consists of screening with a 1 hour 50 gram GCT. If results are abnormal, a confirmatory 3 hours glucose challenge test is performed. Okay. Okay. 24-hour urine 24-hour urine protein collection can diagnose preeclampsia. 24-hour urine protein collection can diagnose preeclampsia. However, second trimester testing is indicated only for systolic blood pressure more than 140 millimeter of mercury, systolic or diastolic more than 90 millimeter of mercury. These patients have blood pressure 132 by 80 millimeter is normal for pregnancy, as is her positional lower extremity edema. A clean catch urine is obtained in all patients at the initial prenatal visit to evaluate for asymptomatic bacteriuria, which is treated during pregnancy due to increased risk for ascending infection, pyelonephritis, The patient is asymptomatic and had a negative urine culture at 10 weeks of gestation, therefore repeat culture is not indicated. And group B streptococcus rectovaginal culture collected at 36 to 38 weeks of gestation. Positive testing required intrapartum antibiotic prophylaxis to prevent vertical transmission, and neonatal patients with GBS colonization GBS colonization in a prior pregnancy do not require early screening or treatment. Transvaginal ultrasound can diagnose a shortened cervix, which increases the risk of preterm delivery. Cervical length is routinely measured on the fetal anatomy ultrasound at 18 to 20 weeks of gestation, and additional measures are not indicated in patients with normal cervical length. Overflow, incontinence, arch overflow, stress, leaking of urine after coughing. Maybe. Wait. Post-viral residue is normal. He has okay. He has spontaneous vaginal delivery, and there is urinary leakage. Leaking of urine. He has leaking of urine without uh, anything like anything cough or anything. Is it obstructed liver? Sorry. Af there is after spontaneous delivery for evaluation. I think that we need to do the bladder dye test. Why is it wait, look at here. Gravita 3 para 3 comes to the office after spontaneous vaginal delivery. See, so she has a history of vaginal delivery. So when we do not know the history of this vaginal delivery, if it is prolonged labor or obstructive labor, sorry, is it right? I am right. Okay, I'm think. Oh, okay, where? Oh, yes. So if urine leaks with Valsalva, then it is stress. I am thinking in another direction. Yes. Is it observation? Okay. Oh, you choose the bladder dye test. What I have told. Oh, yes, yeah. There is one of the question like if there is VVF vesicovaginal fistula because I haven't seen the that point like Valsalva maneuver. Okay, I'm sorry, I am taking you in opposite direction. You are in right direction. Vaginal vault, yes. Yes, we do. Okay, look at the bladder dye testing. Bladder dye testing can help to distinguish VVF, vesicovaginal fistula. Okay, and if there is obstructed labor or prolonged labor, it can happen during vaginal delivery. And she has gravida 3 para 3, so she has the chance of having. Okay. A potential complication of the vaginal delivery, prolonged labor, operative vaginal delivery. Patients typically have persistent urine dribbling from the vagina and urine in the vaginal vault due to direct conduit between the bladder and the vagina. Okay. Stress incontinence, stress incontinence, stress urinary incontinence, urethral hypermobility, and intrinsic sphincter deficiency. So the SUI, U and I is the physiology like urethral hypermobility and intrinsic sphincter deficiency. It is very confusing. That's why I remember through this name on it. Okay. Symptoms is the leakage with Valsalva maneuver, coughing, sneezing, and this and that, sexual intercourse, laughing. Okay. And risk factor pregnancy, obesity, chronic high impact exercise. Chronic high impact exercise. Treatment is pelvic floor muscle exercise, casual exercise, lifestyle modification, weight loss, continued pressure, and mid urethral sling procedure. This postpartum patient with new onset leakage of urine with Valsalva maneuver has stress urinary incontinence due to pelvic floor laxity. Stress urinary incontinence is a common following labor and delivery due to main mechanism weakening of the pelvic floor muscle levator muscle complex which normally support the bladder and the urethra due to increased intra-abdominal pressure with fetal descent and pushing. Pelvic floor weakness causes urethral hypermobility and inability of the urethra to fully compress closed during periods of increased intra-abdominal pressure resulting in leakage of urine with Valsalva maneuver. Stress injury to the pudendal nerve which helps maintain continence because it innervates voluntary contraction of the external urethral sphincter. The pudendal nerve is also main sensory nerve of the pelvis. Damage to it can result in a decreased voiding sensation as seen in this patient. Although postpartum stress in urinary incontinence increases the risk of chronic stress urinary incontinence, most cases are self-limited because the pelvic floor muscles and pudendal nerve heal after delivery. Therefore, patients less than 6 weeks postpartum are managed with observation and reassurance and encouraged to perform Kegel exercise to strengthen pelvic floor muscle. Patients who later have chronic stress urinary continence can be treated with continence specially or mid-urethral sling procedure to compress the urethra to the anterior vaginal wall, thereby decreasing urethral hypermobility. Okay, other like bladder dye test we have found it. Mirabegron beta 3 adrenergic agonist stimulates the beta receptor in the detrusor muscle, smooth muscle relaxation. It is used to treat the urgency incontinence, overactive bladder due to tetrusor hyperactivity, which is not seen in this patient. Okay, this laboring in a patient has epidural analgesia placed for pain management, which provides pain relief throughout the labor by allowing continuous infusion of local anesthetic and opioid, continuous infusion of the local anesthetic and opioid via catheter insertion below L4, below L4, below the L4 vertebra, uh, below the below the L4 vertebra, below the below the spinal cord termination. Spinal cord terminates at L1. Okay, oh, wait. Below spinal cord termination into the epidural space between the ligamentum flavum and the dura. This placement allows for a targeted block of the pain fiber during the first stage, S2 to S4 fibers during the second stage, and which corresponds with the fetal descent into the pelvis. So, which level we actually give? Below below L4, like below L4 means L5. Okay. However, epidural analgesia also blocks sympathetic nerve fibers are responsible for vascular tone in the lower extremity, resulting in vasodilatation, venous pooling, decreased venous return to the heart, and decreased cardiac arrest. Therefore, many patients develop hypotension and compensatory tachycardia because sympathetic innervation of the heart via T1 to T4 is unaffected by the block. Those with significant hypotension can have decreased placental perfusion and late deceleration fetal hypoxemia. Treatment of post-epidural hypotension includes lateral uterine displacement, positioning the patient on the left side, improved venous return, IV fluid bolus, and vasopressor administration, phenylephrine or ephedrine. Okay, yes. Depression of the cervical cord, depression of the cervical cord and the brainstem activity occurs when local anesthesia ascends upward, like high spinal anesthesia. If it ascends upward, so on which level? If we give above L4, then it happens. Okay, if we look at the box or in the picture, then in C3 to 5 it causes dysphagia, respiratory paralysis, C6 to C8 upper extremity weakness, and T1 to T4 bradycardia hypotension. Okay, very grave problem. Okay, high spinal anesthesia may occur with an intrathecal injection or overdose of anesthetic, resulting in sympathetic blockade, hypertension, bradycardia, and a complete motor blockade below the thoracic level, upper extremity weakness, diaphragm paralysis. Leakage of spinal fluid may occur if the dura is inadvertently punctured during epidural placement. These results in leakage of spinal fluid, which causes patient to develop postural headache that classically presents as headache, or worse with sitting up, or improved with lying down after delivery. Hypotension is not characteristic. Opioid toxicity is rare with neuroaxial administration. However, patients with opioid toxicity typically have mild hypotension, bradycardia, and depressed respiratory rate. Okay. Farning negative clue means or nitrogen testing negative means it is not the amniotic fluid. Okay. Look at the biophysical profile. Amniotic fluid volume like single pocket may be less than 1 centimeter if it is okay. I do not know actually the full scenario. Okay. But biophysical profile I know. Look at the biophysical profile. In biophysical profile there is 5 parameter. Non-stress test is one parameter. It is not non-stress test is one parameter, and these four fetal breathing, fetal movement, fetal tone, and amniotic fluid. These are four parameters. Everyone gets 2 point. 2 is the highest point. If it is near about 8 to 10, then it is normal. So this patient already got the 8 point. So it is biophysical profile is normal. That means the fetal well-being is good along with the amniotic fluid. Sorry. No. Yes, it's fine. Weird is only if you get the sinusoidal pattern like a simil and look at the heart rate. It is in between 120 to 160 or 110 to 160. So fetal heart rate is normal. If it is above 160 like 190 20 or 220, then fetal heart rate, then the fetal breathing is compromised. And if we don't know the picture, if we look at the biophysical profile is all right. Everyone gets his own 2 points, so it is on the fetal well-being is good. Okay, if we I'm reading the box first because it is important. Okay, first non-stress test. We have found a question of non-stress test. Okay, non-stress test, external fetal heart rate monitoring for 20 to 40 minutes. If the baby is sleeping, then we need to do this test up to 120 minutes. Okay, okay. If it is reactive, that means there is two acceleration. That this baby got the 2 point. If no acceleration or variable or late deceleration, or he may got the 0 point. If the non-stress test is negative, like if the baby does not get um, total point, total 2 point, then we have to think that the baby is compromised. After this non-stress test, if it is Like if you get non-stress test is 0, immediately you should do a biophysical profile. Like it's an ultrasonogram, but it is told that ultrasonography of the biophysical profile. If non-stress test plus ultrasound assessment, like what ultrasound assess these four parameters: amniotic fluid volume, fetal breathing, fetal movement, and fetal tone, each got 2 points. If it is 8 to 10, then it is normal. If it is 6, it is equivocal. If it is 0 to 4, then it is abnormal. And sometimes oligohydramnias can be found if amniotic fluid volume is low. Now, contraction stress test. External fetal heart rate monitoring during external fetal heart rate monitoring during spontaneous or induced oxytocin or nipple stimulation, uterine contraction. No late or recurrent variable deceleration is normal. If there is late deceleration uh, and more than 50% contraction, then you have to think about it is abnormal. The contraction stress test. Now the Doppler sonography of the umbilical artery, evaluation of the umbilical artery flow in fetal intrauterine growth restriction only, high velocity diastolic flow in the umbilical artery, abnormal or absent, decreased, absent, or reversed in diastolic flow. Okay, have you understand the box? Okay, this patient at 35 weeks of gestation, this patient uh, at 35 weeks of gestation is evaluated for possible pre-labor rupture of the membrane, pre-prom, patients with high-risk feature pregnancies or acute obstetric conditions suspected PPROM, vaginal bleeding, decreased fetal movement require evaluation for fetal well-being with a non-stress test. Fetal well-being with a non-stress test, which is continuous fetal heart rate monitoring for 20 to 40 minutes. A non-stress test is normal or reactive if two or more than two fetal heart rate acceleration are present with normal baseline variability, no deceleration, including that the fetal oxygenation is adequate and the risk of fetal acidemia is low. In contrast, this patient has non-reactive non-stress test result. Non-reactive non-stress test result less than 2 acceleration, which can be due to benign cause fetal sleep cycle or indicate potential fetal hypoxia or acidemia. Because a non-reactive non-stress test result is non-specific, it requires further evaluation with a biophysical profile with a ultrasound test that assigns a score 0 to 2 to each of the following five parameters: NST, fetal tone, movement, breathing, and amniotic fluid. An 8 of 10 score as this patient, 2 minus 2 for non-reactive stresses is normal. Patient with non-reactive non-stress test result and normal BPP score receive reassurance and routine care. Okay. Is it due to hypertension? Oh no, sorry. This patient with this patient with prolonged labor, retraction of the fetal head into the perineum after delivery, turtle sign, likely has shoulder dystocia. That means inability to deliver the fetal shoulders with the usual obstetric maneuver. Shoulder dystocia is an obstetric emergency due to risk for neonatal brachial plexus injury, clavicular and humeral fracture if prolonged hypoxic brain injury or if prolonged hypoxic brain injury and death. The greatest risk factor for shoulder dystocia is fetal macrosomia, defined as estimated fetal weight more than 4.5 kg. A common sign is uterine size greater than the date, as in this patient with a fundal height measuring 43 cm at 39 weeks of gestation. Other risk factor for shoulder dystocia are conditions that predispose to macrosomia, including postpartum pregnancy, gestational diabetes mellitus, maternal obesity, excessive maternal weight gain, as in this patient with pre-pregnancy BMI of 32 kg per meter square. However, shoulder dystocia also frequently occurs in patients with no risk factors and can difficult to predict. Yes, a short interpregnancy interval less than 6 to 18 months from delivery to next conception is a risk factor for uterine rupture due to myometrial weakness. In contrast to turtle sign, head retracting tightly against the perineum, uterine rupture typically leads to loss of fetal station. While the infant is in utero, patients usually have acute abdominal pain and a new abdominal mass, fetal body delivering into the abdomen. Bulky lower uterine segmental fibrosis may prolong the second stage of labor, but they are unlikely to obstruct delivery of the fetal shoulder if the head can be delivered. This is because the surrounding myometrium can stretch to accommodate fetal size. In contrast, the pubic bone is hard and unyielding. Okay. Okay, can you give me a minute? Like 5 minutes? Okay, I'm coming. Okay. This patient with hypotension, tachycardia, and signs of end organ perfusion, fatigue, lightheadedness, cold skin, most likely has hypovolemic shock due to PPH. Postpartum hemorrhage typically occurs within hours of delivery. Uterine atony is the most common cause. Therefore, initial evaluation require bimanual examination to assess for enlarged boggy uterus and heavy vaginal bleeding consistent with atony. In contrast, post-caesarean delivery patient with hemorrhagic shock and no signs of uterine atony, such as this patient, most likely have intra-abdominal bleeding from uterine artery injury. Because pregnancy increases uterine artery blood flow, an intrapartum uterine artery injury can lead to rapid and massive blood loss with subsequent hemodynamic instability. This patient's bleeding is most likely located in the retroperitoneal hematoma, which is a rare but life-threatening cause of PPH that typically presents with no incisional bleeding and minimal abdominal or back pain. As the retroperitoneum has a vast potential space for blood accumulation before build-up build-up pressure causes peritoneal stretching and pain. Hemodynamically unstable patient with a suspected retroperitoneal hematoma require emergency laparotomy. Next, tocolysis. It causes uterine relaxation, so it actually stops. Here, on the DRE, the cervix is 4 centimeter dilated, 90% effaced. Is it CS? Oh no, transfusion models. Digital cervical examination. Digital cervical examination is used to determine cervical dilatation and fetal presentation. The fetal part, head, buttocks, umbilical cord, head, buttocks, umbilical cord, directly overlying the pelvic inlet. Information required for labor management. Fetal presentation is variable. Fetal presentation is variable and can change from week to week. Even in term pregnancy, even in term pregnancy, the patient at 37 weeks of gestation is delivering and has a taut, bulging abdominal bag with no palpable presenting part on cervical examination. Digital cervical examination is usually adequate for determining fetal presentation for more so than Leper's maneuver abdominal palpation. However, it may be insufficient in patients with bulging bag, which may be a normal finding when uterine contraction tense the amniotic sac. If fetal presentation is in, indeterminate on cervical examination due to bulging amniotic sac or high fetal station, transabdominal ultrasonography is performed to confirm pulsation or to confirm presentation, which is necessary to determine the route of the delivery. Patients with cephalic presentation can be managed expectantly in the anticipation of the vaginal delivery. Conversely, breech or other non-cephalic transverse fetal presentation should be managed by cesarean delivery to avoid the increased risk for neonatal death associated with breech vaginal delivery. Okay. Yes. Although an amniotomy or iatrogenic rupture of the membrane is often performed with labor induction, it is often unnecessary for patient in spontaneous labor because it does not decrease the duration of the first stage labor or reduce caesarean delivery rates. When there is no palpable presenting part, transabdominal ultrasonography must be performed before amniotomy to avoid umbilical cord prolapse in patients with phonic cord first presentation. So when fetal part is not palpable, when there is no palpable presenting fetal part, transabdominal ultrasonography must be performed first before amniotomy to avoid the cord prolapse. Okay. An external cephalic version is performed to perform forward roll. External cephalic version is performed to convert non-cephalic presentation to cephalic. Non-cephalic presentation to cephalic. Fetal presentation is determined via transabdominal ultrasonography prior to this procedure. Okay. If there is there is buttock presentation, then we will try to move the baby into head position in the utero. Is it done outside or is it done outside? External caf, yes. Like how it Yes, the hand of the doctor should be outside like in the abdomen. Okay, hand of the doctor. Okay. and she had underwent an uncomplicated hysteroscopic resection. So there is a procedure, there may be adhesion. Is it Asherman? Okay. Intrauterine adhesion it may be due to infection, septic abortion, endometritis, and intrauterine surgery, curettage, myomectomy. Clinical feature: abnormal uterine bleeding, amenorrhea, abnormal uterine bleeding, amenorrhea, infertility, cyclic pelvic pain, recurrent pregnancy loss, and hysteroscopy. Infertility is the ability to conceive after 6 months of unprotected intercourse. Infertility is the inability to conceive after 6 months of unprotected intercourse in women aged more than 35 or more than 35, or after 12 months in women less than 35. This patient's infertility, secondary amenorrhea after our hysteroscopic myomectomy is likely due to Asherman syndrome, the development of symptomatic intrauterine synechia. Patients such as these one who undergo intrauterine surgery, hysteroscopic myomectomy, curettage are at risk of damage to the endothelial are damage to the endometrial basalis layer, which creates an inflamed denuded endometrium that causes the uterus to adhere to itself, resulting in obliteration of the uterine cavity. The lack of endometrium results in the development of light means secondary amenorrhea, infertility due to lack of implantation, and a negative progesterone withdrawal test. So despite normal estrogen and progesterone level, some patients may have cyclic pelvic pain if the endometrial cavity is not totally obliterated. If the endometrial cavity is not totally obliterated due to small pockets of obstructed proliferative endometrium, a hysteroscopy is performed. A hysteroscopy is performed for diagnosis and treatment via lysis of adhesion. Yes, a uterine septum. A uterine septum is an u, a uterine septum is an uterine lateral fusion defect resulting in two uterine cavities due to small and poorly visualized uterine cavities. Patients with septate uterus are at increased risk of recurrent spontaneous abortion, fetal growth restriction, and preterm delivery. A uterine septum does not cause amenorrhea or infertility.
exactly.
She
It
stopped tobacco before conception, isn't it?
prior to
Conception. So his blood pressure is higher. Okay. Is it inaccurate pregnancy dating? He has ASD. Is it due to lithium or other? He has maternal psychiatric. Is this okay? It's I missed. Okay. Fetal growth restriction. Fetal growth or restriction. Is it symmetric or asymmetric? Uh, but I think that as it is in the second trimester, like 26 weeks of gestation. Okay. So how will differentiate the symmetric and asymmetric? Okay, I'm reading the box. Ultrasound estimated fetal weight less than 10 percentile or birth weight less than third percentile for gestational age. Fetal weight less than 10 percentile and fetal birth weight less than third percentile. In here, fetal weight is at fourth percentile. Okay. Onset is symmetric is first trimester, asymmetric is second or third trimester, symmetric is chromosomal abnormality and congenital infection, and asymmetric is uteroplacental insufficiency and maternal malnutrition. Symmetric is global growth lag, and asymmetric is head sparing growth lag. Head sparing growth lag management, regular non-stress testing, weekly biophysical profile, serial umbilical artery Doppler ultrasonography, and serial growth ultrasounds. Okay, fetal growth restriction is defined as an ultrasound estimated fetal weight is less than 10 percentile. Ultrasound estimated fetal weight is less than 10 percentile or birth weight is less than third percentile for gestational age. Fetal growth restriction is classified as following. Symmetric fetal growth rate is a global proportionate growth lag that uniformly affects fetal organs and often begins in the first trimester from any early insult that inhibits cellular growth and expansion. The most common cause of symmetric fetal growth restriction is fetal chromosomal anomalies followed by first trimester congenital infection, toxoplasmosis, and cytomegalovirus. Asymmetric fetal growth restriction is disproportionate growth lag predominantly affecting the abdominal circumference, uteroplacental insufficiency, or impaired blood flow through the placenta causes the fetus to preserve blood or oxygen to vital organs, brain, heart, placenta as the expense of less vital signs, abdominal viscera, resulting in head sparing fetal growth restriction. Asymmetric fetal growth restriction is associated with maternal hypertension, and tobacco use during pregnancy. Maternal hypertension and tobacco use during pregnancy. Okay. So, this fetus has estimated weight less than 10 percentile and a symmetric growth lag of the head, symmetric growth lag of the head and abdomen. This growth lag seen at the anatomy ultrasound suggests a process that started early in the pregnancy. The, art, the atrial septal defect. The atrial septal defect, these patients age more than 35 are suggestive of an underlying chromosomal abnormality, trisomy 21. Okay, yeah. Is it the type of exercise? Oh, what, what thinking? I have seen the history of eating.
Pepper the arms.
Okay. Okay, pregnancy and pregnancy and exercise, amniotic fluid leak, cervical insufficiency, maternal, multiple gestation, placental abruption or previa, preterm labor, preeclampsia, gestational hypertension, severe heart disease or lung disease, unsafe activities, contact sports, basketball, ice, hockey, mm, soccer, high fall risk, downhill skiing, gymnasts, horseback riding, scuba diving, and hot yoga. Exercise during pregnancy can be beneficial. Exercise during pregnancy can be beneficial and is associated with decreased risk of excessive gestational weight gain, decreased risk of excessive gestational weight gain, gestational diabetes mellitus, preeclampsia, caesarean delivery. Therefore, low risk patients who exercise regularly Therefore, low-risk patients who exercise regularly prior to pregnancy are encouraged to continue moderate intensity exercise during pregnancy. However, exercise during pregnancy may exacerbate some obstetric condition. Therefore, it is contraindicated. Therefore, it is contraindicated in certain patients. Exercise should be avoided by patients at high risk for preterm birth, cervical insufficiency or sarclage, preterm labor during current pregnancy, preterm pre-labor rupture of the membrane, patients at risk for antepartum bleeding, Placenta patients at risk for antepartum bleeding is placenta previa and persistent second or third trimester bleeding. Patients with underlying condition that could be exacerbated by exercise, severe anemia, hemoglobin less than 8, hypertensive disorder for pregnancy, preeclampsia, restrictive lung disease, hemodynamically significant heart disease. Cervical insufficiency is a cervical structural weakness associated with painless second trimester pregnancy loss. Patient with cervical insufficiency based on a history of 2 prior losses are at high risk for recurrent pregnancy loss. This risk can be decreased by placing a prophylactic circlage, a suture placed around the cervix to reinforce its stability, and avoidance of moderate to high intensity exercise such as running and weightlifting. Yes. Normal, oh, I don't remember actually. Maybe more than 15 centimeters. Or is it 25? I do not know. Typically 5 centimeter to 24 centimeter. Normal amniotic fluid index. Typic, typical 24 centimeter. Okay. This patient 26 weeks of gestation. So okay. This patient's 26 weeks of gestation has preterm pre-labor rupture of the membrane based on leakage of nitrogen positive fluid, nitrogen positive fluid, alkaline amniotic fluid emerging from the cervix. Risk factor for pre-prom include prior pre-prom, as in this patient, genitourinary infection, antepartum bleeding, uncomplicated antepartum bleeding, and uncomplicated cases of pre-prom are managed expectantly with inpatient monitoring, serial fluid ultrasound, prophylactic latency antibiotic, corticosteroid, and delivery at 34 weeks of gestation. However, patients who develop complication, placental abruption, cord prolapse, do not meet criteria for expectant management. This patient has fever, fetal tachycardia. This patient has fever and fetal tachycardia consistent with intraamniotic infection, that is chorioamnionitis, a fulminant polymicrobial infection of the amniotic sac, fetus, cord, and placenta from ascending vaginal flora. Additional signs may include maternal tachycardia, uterine tenderness, and malodorous or purulent amniotic fluid. Intraamniotic infection has an increased risk of maternal morbidity, sepsis, DIC, and mortality that outweighs the fetal benefit gained by prolonging pregnancy. Therefore, patients with pre-prom complicated by intraamniotic infection require therapeutic antibiotics and immediate delivery, induction of labor regardless of gestational days. Okay, sorry. Yes, fetal fibronectin fetal fibronectin is used to identify with preterm contraction who are at high risk for preterm delivery. It is not performed with pre-prom because the risk of preterm delivery is high and therefore not does not change management. Therefore does not change management. Fetal lung maturity testing is performed in patients with uncertain gestational dating to determine timing of the delivery, that is prolonged pregnancy for fetal benefit. Neither of these tests is indicated because these patients require immediate delivery. And in uterine rupture, BP will be not that normal. Is it due to malposition? Okay, it's the second stage of arrest of labor. Insufficient fetal descent. after pushing for more than 3 hours in nulliparous and more than 2 hours in multiparous. She quickly dilates 10 centimeter, fetal vertex 0 transverse. After 4 years, look, there is unchanged. The after 4 years, minimum 2 centimeter. I am trying to correlate with the answer. Look at, she quickly dilates 10 centimeter in the question. Quickly dilates 10 centimeter with no fetal, with zero station. Got it? After 4 hours, the pelvic examination shows no change. After 4 hours, there should be some sort of fetal descent. If insufficient fetal descent after pushing more than 3 hours in nulliparous and more than 2 hours in multiparous, it is second stage arrest of liver. It may be due to maternal obesity, excessive pregnancy weight gain, and diabetes mellitus. Uh, okay. Etiology is cephalopelvic disproportion, malposition, inadequate contraction, maternal exhaustion. Management: operative vaginal delivery, cesarean delivery. The second stage of labor begins when the cervix is 10 centimeter dilation and ends with fetal delivery. The duration of the second stage is affected by parity and the use of neuroaxial anesthesia. Progression during second stage labor is evaluated by determining the fetal station, which measures the descent of the fetal head through the pelvis. A second stage arrest of labor, an arrested second stage occur when there is no fetal descent after pushing more than 3 hours in nulliparous patient and more than 2 hours in multiparous patient. The patient functionally this patient functional nulliparous because her child was cesarean delivery for breech presentation. This patient is functional nulliparous because her first child was cesarean delivery. A common cause of protracted or uh, arrest second stage is fetal malposition. Fetal positioning is the relationship of the fetal presenting part to the maternal pelvis. The optimal fetal presentation is occiput anterior. It facilitates the cardinal movement of labor. Deviation from this position occiput transverse can cause cephalopelvic disproportion in the second stage of labor. Okay. Yes. Inadequate contraction less than 200 Montevideo units average over 10 minutes are commonly lead to labor arrest. This patient's contraction is adequate. Less than 200 Montevideo is inadequate contraction, but this arrest is not due to contraction. Okay. A and D. D. Mole B. Sorry. Okay. C. Maternal obesity and excessive weight gain during pregnancy are also risk factors for second stage arrest. This patient has normal pre-pregnancy BMI and has an appropriate weight gain Okay. I- I- okay. In this first we need to identify the second stage arrest of liver. Then we need to find the cause. First look, she quickly dilates to the 10 centimeter. And that means she has full dilation, 10 centimeter dilation. After 4 hours, there is the pelvic examination is unchanged. So after full dilatation, there need there we need some sort of improvement in the fetal descent, but there is no fetal descent. That's why it is arrest. And in the arrest, one of the causes is fetal malposition. And he has occiput transverse. Occiput transverse is what the baby is lying transversely, not in the buttock position, not in the head position. Normally, if head, normally head, normal position is like breech position. No, no, breech, not breech. Cephalic presentation. Cephalic means head is in the in the vaginal direction. So is it easily comes out. If it is breech or buttock position, it also comes, but it needs some effort. But when the baby is lie transversely, it is problematic. So it is malposition. Probably yes. His age is her age is higher. So we need okay cell-free fetal DNA testing. Cell-free fetal DNA testing. Maternal age is more than 35. Abnormal maternal serum screening test. Sonographic finding associated with fetal aneuploidy. Prior pregnancy with fetal aneuploidy. And parenteral balanced Robertsonian translocation. Screening for trisomy 21, 18, and 13 and 6 chromosome aneuploidy. And fetal sex determination. The initial prenatal visit uses The initial prenatal visits uses a combination of maternal history and prenatal testing to identify patients at risk for obstetric complication. Prenatal testing can be routine, HIV screen, maternal blood typing, or risk-based. Women age more than 35, advanced maternal age are at increased risk of fetal aneuploidy are offered cell-free DNA testing of maternal plasma. Other indications include abnormal maternal serum screening test result, quadruple screen, or an abnormal ultrasound. Non-invasive cell-free fetal DNA testing can be performed at more than 10 weeks of gestation and high sensitivity and specificity for detecting trisomy 21, trisomy 18, and trisomy 13. It can also identify the fetal sex and some sex chromosome disorder. Normal results are reassuring and typically requiring no additional evaluation. Abnormal results are confirmed by fetal karyotyping via first trimester chronic villus sampling or second trimester amniocentesis. Normal. So abnormal result confirmed by first trimester chronic villus sampling or second trimester amniocentesis. Okay. So it's this cell-free fetal DNA testing is not confirmatory. Okay. And quantitative beta HCG levels are indicated in patients with a pregnancy of unknown location because abnormal levels may indicate an ectopic pregnancy. Beta HCG levels have no clinical value once an intrauterine pregnancy is confirmed on ultrasound, as in this patient. Okay.
My heart rate 160, normal reading.
Is it painful vaginal bleeding?
Vaginal bleeding is possible. Yes,
Le- early late deceleration is cock like uh, mm, sorry. Late deceleration is uteroplacental insufficiency. Yeah, maybe. And abruptly placenta can come with the bleeding, closed cervix bleeding, and there is constant back pain. So pain is there, painful vaginal bleeding. That's why I'm asking you. If it is painful vaginal bleeding after 20 weeks, this is abruptio placenta previa. And after 20 weeks, painless vaginal bleeding, painless, causeless, recurrent vaginal bleeding, it is placenta previa. Painless, causeless, recurrent. No, just like painless vaginal bleeding. There is not that thing. Painless. As per I remember, 20 weeks. Yes. Time. Yes. Okay. This patient with vaginal bleeding, a firm distended uterus, and a fetal deceleration has abruptio placentae. Placental abruption occurs when maternal vessels rupture at the uteroplacental interference, causing premature separation of the placenta from the uterus. A common risk factor is chronic hypertension. Maternal hypertension, regardless of well-controlled blood pressure, is associated with widespread and is associated with widespread endothelial dysfunction. This dysfunction impairs normal development of the spiral arteries that supply the blood to the fetus and the placenta. The result is abnormally high resistance spiral artery that lead to normal placental perfusion, ischemia, and possible infarction, all of which increase the risk of abruptio placentae. In addition, chronic endothelial dysfunction increase the vessel frailty and the risk of vessel rupture at the uteroplacental interference. Other risk factors for abruptio placenta include tobacco, cocaine due to placental ischemia, and abdominal trauma. Although most patients with abruptio placentae have heavy vaginal bleeding, up to 20% have minimal or no bleeding because blood is concealed within the intrauterine cavity. These patients typically have focal pain, back pain, suggests posterior placental rupture, an abnormally distended uterus measuring 38 centimeter at 35 weeks of gestation, and high frequency contraction due to increasing intrauterine pressure and volume. As more of the placenta detaches, the fetal hypoxia can occur, as an evidence by abnormality of the fetal heart rate and tracing late deceleration. Okay. Okay. The preterm is a preterm labor is contractions that cause cervical dilatation at less than 37 weeks of gestation. Labor pain is typically intermittent because the uterus relaxes between contraction. In contrast, this patient has constant pain and a closed cervix. Uterine rupture commonly causes abdominal pain, vaginal bleeding, and fetal heart rate abnormalities. However, patients typically have diminishing contractions and fetal pulse palpable through the maternal abdominal wall. Vasa previa can present with vaginal bleeding due to injury to the blood vessel overlying the cervix. However, the bleeding is typically painless. Okay. Yes. 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 Vasa previa is fetal blood vessel, and it is painless. And placenta previa is painless, but maternal. Okay. Okay. Okay, it's continue to okay. Fetal heart rate. Can you hear me?
Yeah.
Okay, fetal heart rate tracing, moderate variability. Fetal heart rate tracing, moderate variability. 6 to 25 per minute, and early deceleration. Early deceleration have a slow onset, more than 30 seconds from onset to nadir, and occur symmetrically with contraction. This patient is characteristic uniform shallow deceleration with the nadir at the peak of the contraction and return to the baseline at the end of the contraction. Early deceleration are caused by fetal head compression, though fetal head compression these occur when the fetal head descends to these occur when fetal head descends closer to cervix, each which contracts and causes narrowing of the fetal anterofrontally. The narrowed anterofrontally causes a transient alteration in the cerebral blood flow, which stimulates a vagal response, slows the heart rate. Early deceleration being a physiologic finding and does not indicate fetal hypoxia. Therefore, these deceleration do not require intervention and can be managed expectantly. Okay, yes. Caesarean delivery is indicated for concerning category 3 fetal heart rate tracings like absent where fetal heart rate tracing which reflect fetal compromise. These tracing may show absent variability plus fetal bradycardia. So absent variability and fetal bradycardia. Look at the heart rate. It's getting down in the baby. So yes,
Okay.
yes,
Final interrogate reversing arrhythmia right arm. Patient is presenting with exudation tendency on the left leg. Cardiac obstruction and bradycardia with reduction in pulsing and
baby's weight is very high. Fetal high. mm, Okay. Maternal hyperglycemia. Maternal hyperglycemia first trimester is the CNS like congenital heart disease, neural tube defect, and small left colon syndrome and spontaneous abortion. And maternal hyperglycemia second and third trimester is fetal hyperglycemia and hyperinsulinemia. Fetal hyperglycemia and hyperinsulinemia increases metabolic demand, causing fetal hypoxemia, increased erythropoiesis, that means polycythemia, and fetal hyperglycemia causing organomegaly, neonatal hypoglycemia, And macrosomia, shoulder dystocia, it can cause a brachial plexopathy, cervical fracture, perinatal asphyxia, and increased glycogen synthesis, glycogen deposition in the interventricular septum, and hypertrophic cardiomyopathy. So these neonates birth weight is consistent with macrosomia, fetal weight more than 4 kg, and his physical examination findings reflect complications of the shoulder dystocia. Fetal hyperglycemia is the most common underlying risk factor. Mild maternal insulin resistance is a physiologic process of the pregnancy that facilitates the diffusion of glucose across the placenta for fetal growth. However, excessive maternal hyperglycemia, gestational or pre-pregnancy diabetes mellitus results in fetal hyperglycemia, which increases fetal pancreatic insulin secretion, causing fetal hyperinsulinemia. Excessive production of fetal insulin and anabolic hormone leads to macrosomia with disproportionate growth and fat accumulation over the shoulders and abdomen. As a result, the shoulders can become impacted in the maternal pelvis, resulting in shoulder dystocia and obstetric emergency. Potential complications of shoulder dystocia include clavicular fracture, brachial nerve palsy, perinatal asphyxia, hypoxic encephalopathy. Maternal hyperglycemia can also lead to neonatal polycythemia and plethora as well as postnatal hypoglycemia. Fetal hyperglycemia and hyperinsulinemia likely contribute to the patient's macrosomia, plethora, shoulder dystocia with resultant clavicular fracture, crepitus, asymmetric Moore reflex. Next.
Majorly over 85% of mothers report this patient is identified with complicated birth during pregnancy.
Yes. Is it preterm? Other things does not match. Fetal anemia does not happen maybe because he is on iron supplementation.
Okay, yeah, this is
It is just his weight is not uh, he is not gaining up to the mark. Maybe preterm. Okay. Should we need to remember these box?
yes, no worries.
Okay, we just only read the complication. If weight gain is pregnancy is not up to the mark, inadequate weight gain, low birth weight, and preterm delivery. Excessive weight gain can cause gestational diabetes mellitus, fetal macrosomia, and cesarean delivery. So during pregnancy, women have increased nutritional requirement because Both calories and nutrients, folate, calcium, iron, are preferentially shunted to developing folate, calcium are preferentially shunted to the developing fetus to meet the metabolic demand. Average women should increase intake approximately 350 to 450 mm, women should increase intake by approximately 350 to 450 kilocalorie per day in the second and third trimester. The target for gestational weight can depend on pre-pregnancy BMI, which is an indicator of the baseline of maternal fat and nutrient store. Because patients with underweight pre-pregnancy BMI less than 18.5 kg per meter square have low baseline store and therefore require greater weight gain, more than 1 pound, zero point 0.5 kg per week to maintain a healthy pregnancy. This patient is both underweight and inadequate gestational weight gain, which along the lagging fundal height 24 centimeter at 26 weeks of gestation, fundal growth is 25 percentile suggests that this patient's nutrition may be insufficient for appropriate fetal development. The depleted state increases the risk of pre-pregnancy related complications include a preterm delivery, which occurs when the patient can no longer shunt enough nutrient to support the fetus, and low birth weight, small for gestational age of infant. Okay,
New incident.
yes. Risk factor for placenta previa include prior cesarean delivery due to uterine scarring and multiple gestation. Yes. Plus a risk factor for placental abruption. A risk factor for placental abruption include abdominal trauma, conditions that disrupt the vascular integrity of the placenta, maternal hypertension, smoking, cocaine use. Inadequate gestational weight gain is not associated with placental abruption.
Very looking at the questions later. First, what is metabolic pregnancy? We'll talk
Is it that box like symmetric and asymmetric? Yes, 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 maybe yes, asymmetric. It is and it happens in the second and third trimester. So asymmetric first trimester is double C, like congenital infection and maybe congenital infection for first trimester, isn't it? Yes, and his second trimester, his what's his blood pressure? Its blood pressure is 140 over. Is it normal? What's his BMI? BMI is normal, 26. May not. So maternal hypertension. Even if she is taking medication, BP is 140, 80. So it's high. Okay. So fetal growth restriction. Okay, fetal growth restriction is defined as estimated fetal weight. Estimated fetal weight less than 10 percentile or birth weight less than third percentile for gestational age. Fetuses with growth restriction have increased risk for intrauterine fetal demise and neonatal morbidity or mortality preterm labor. Okay, FGR fetal growth restriction uh, characterized as either symmetric or asymmetric. Symmetric fetal growth restriction is uniform and equal global growth impairment, head, femur, abdomen that begins in the first trimester due to an early and developmental insult, aneuploidy, or congenital infection. Okay, in contrast, asymmetric fetal growth restriction. Asymmetric fetal growth restriction is disproportionate growth impairment due to uteroplacental insufficiency and subsequent chronic fetal hypoxia, maternal conditions such as hypertension and pregestational diabetes predisposed to abnormal placental development that causes progressive placental dysfunction during the late second and third trimester. The fetus adapts to impaired the fetus adapts to impaired blood flow and reduced oxygen delivery by redistributing blood to the vital organs, brain, and away from non-vital organs, abdomen, causing a head-sparing growth pattern. In this patient, fetal head is 2 weeks smaller, but the abdomen is 7 weeks smaller than expected for gestational age, indicating asymmetric fetal growth restriction. Maternal hypertension is most likely the cause, even when small, well contracted hypertension can cause underdevelopment of the spinal arteries in the placenta, resulting in increased vascular resistance and reduced blood flow. Okay. Initially, I understand in wrong way in fetal growth restriction. I thought that if it happens in the second and third trimester, it should be uteroplacental and maternal malnutrition. No, no, it happened in the second and third trimester. It is not the timing. It is I am unable to make you understand like what that means, that if it is symmetric, that means it is started in the first trimester. If it is asymmetric, it starts in the second and third trimester. But I always look at the time uh, when it is done, like what is gestational age. I thought that if gestational age is 34 weeks, so it is symmetrical, or is it is asymmetrical. It is not the gestational age timing. It is the time when it starts. Yes. difficult. Maybe engorgement, because lactational mastitis can come with fever. Am I am I right? Okay. Okay. Uh, this patient has breast engorgement, which commonly occurs 3 to 5 days after delivery, when colostrum is replaced by milk. When the colostrum is replaced by milk, requiring in high high milk production volumes. This engorgement is exacerbated by a physiological increase in interstitial edema from decreasing progesterone levels after delivery. Engorgement may also occur during times when milk accumulation exceeds drainage. Breastfeeding, weaning, waning. Patients with breast engorgement have bilateral breast fullness with diffuse tenderness and erythema. Cold compresses, acetaminophen, and NSAIDs may be used for symptom control. Patients should experience improvement as breastfeeding or regular pumping is established. Okay, A and D. In contrast, in contrast to this patient, those with lactational mastitis often have flu-like symptoms, fever, myalgia, and unilateral breast pain with a focal area of erythema and tenderness. Breast abscesses appear like mastitis and associated areas of fluctuance and axillary lymphadenopathy.
Erythema.
Yes, engorgement is bilateral, symmetric. Engorgement is bilateral, symmetric, fullness, tenderness, and warmth. Nipple injury is abrasion, bruising, cracking, or blistering from pore latch. Plugged is focal tenderness, firmness, or erythema, but no fever. Galactocele is subareolar. Galactocele is subareolar, mobile, well circumscribed, non-tender mass, no fever. Mastitis is tenderness or erythema with fever, and abscess is mastitis or with fluctuant mass. Yes.
Like, could you add why is inspired cause of that how
Intracranial calcification. Yes. CMB may be periventricular calcification, isn't it? Okay. So these patients' ultrasound findings suggestive of congenital toxoplasmosis, maternal toxoplasma gondii infection can occur via consumption of undercooked contaminated meat through contact with the feces and or of infected cat, which is the definitive host of the protozoan oocyst. And although asymptomatic, adults can have fever, lymphadenopathy, myalgia, and or diffuse non-pruritic maculopapular rash that resolves spontaneously as seen in this patient. Although maternal infection is mild, transplacental vertical transmission can result in devastating fetal infection. Toxoplasma gondii preferentially destroys the fetal neural tissue, which results in ultrasound findings of bilateral ventriculomegaly, hydrocephalus, and diffuse parenchymal intracranial calcification, particularly within the basal ganglia. Additional fetal findings associated with congenital toxoplasmosis and non-specific and may include ascites, hepatomegaly, or fetal growth restriction weight less than 10%. The patient should undergo amniocentesis for Toxoplasma gondii, PCR testing of amniotic fluid to confirm the diagnosis, prenatal antitoxoplasma therapy, pyrimethamine, sulfadiazine, folinic acid may decrease the risk for neurological sequelae such as chorioretinitis, seizures, and intellect, in, intellectual disability. Okay, okay, yes. I okay, okay. One thing I want to say.